Hello, everyone, from wherever you are joining us today for the latest Surgery International webinar. Thanks for joining us for today. And we have an exciting area to discuss between our esteemed guests on our panel. I'm Shafi Ahmed. I'm, of course, the founder and connect surgeons from around the world. We have 20,000 surgeons now connected across 140 countries, all discussing the future of surgery. We have an important announcement to make soon. We're going to be launching a Leaders Summit for the first time next year that you'll be invited to come along to discuss the very future we'll be discussing today. The team here now discuss the very concept of the importance of post-surgical follow-up. Without further ado, we're going to introduce them one by one, or let them introduce themselves, in fact. So, Chindu.
Yes, thank you, Shafi. It's a pleasure to be here. My name is Chindu Kabir. I'm an orthopedic surgeon. Well, I can't really call myself that anymore because now I'm fully into technology. So I am the CEO of Post-op, a technology platform uh, focused on bringing equitable perioperative care in surgery.
Thank you, Chindu. Ashish.
So my name is Ashish Kelkar. I'm a colorectal surgeon, clinical lead at Kettering, part of Northamptonshire Group Hospitals. And my special area of interest is bowel cancer, but also do a lot of day surgery, laparoscopic surgery. The post-op app that we've been using is an absolute revelation, and I'd like to share that with you.
Thank you so much for joining us, Ashish and Adriana.
Hi, Shafi. Thank you for inviting us. I work in the same place as Ashish does as well. My main area of interest is actually day case surgery. I'm the lead for it, for surgery. And I have met Chindu absolutely randomly. I had the pleasure of using the post-op, which has been a great help. And I think the webinar is the way to move forward because we often forget about post-op care for the patients.
Yeah, look, I've been a surgeon now for 32 years. I've kind of done my 3 decades in the NHS. And post-op care has been so fragmented, so disjointed, and not consistent across any healthcare system that I've ever seen. So I'm glad this is an area that I think is ripe for disruption. I'm glad that you're challenging it with some solutions that you're going to provide and discuss today with us on the webinar. Service. We have to do better. We have to prevent people from going back into hospital. That kind of disruption. So, Chindu, from your perspective as a surgeon, you're still a surgeon, by the way, Chindu. We still give you that one.
Well,
Obviously, you moved to the tech sector as CEO. What were the things you were thinking about? Saying, hey, there's a problem here that I need to solve.
Well, ever since I started surgery, which about 25 years ago, I've always asked people, why is it that we're being able to standardize the actual surgery globally? Like you could do a hip replacement in the same way, whether you're in Malawi, London, or New York. However, in the same hospital, two different surgeons doing this similar surgery would follow up patients in two different ways, right? It's the lack of standardization that really shook me because if you ask any surgeon yourself, you would say the most dangerous period for a patient is the immediate post-operative period for the first week or month. We used to have good follow-up care where our primary care colleagues would pick up our patients and look after them. But care now is very fragmented. It's not just here in the UK, anywhere in the world. We have yet to standardize the perioperative care. I'm inspired by Atul Gawande's book on, the WHO checklist. By doing some very simple checklist, we were able to, improve the safety of patients. We can do the same for the perioperative journey as well.
You're right. We spent a lot of time thinking about the operation. Let's go back. I remember when getting it right first time. So GIRFT is a kind of a narrative from the NHS and NHS England, as it was then, around how to improve care during the operation. So we standardize, so there's less variation. And variation is the key word. We know that variation is a problem globally, which affects outcome adversely. So I think you're right. One of the things we need to address is what does that post-op care in the immediate perioperative and post-operative period also for follow-up and long term? Again, there are different views on this and how we manage that. And of course, there's also incentives or lack of incentives to follow up patients or do adequately. So a lot of issues that float around. Um, Adriana, I know that you've been using some of the platforms that we can describe in a moment. Give me your thoughts around how you've been using the ideas and how it may have transformed patient care in your eyes.
So when they started here, I think post-op was mainly designed for follow-up for orthopedics patients. And it's been quite numerous of conversations with me and my colleagues and Chindo and his team as well to adapt the follow-up from orthopedic to a surgical perspective. So we changed a few of the questions, how we follow them up, and has been running now in surgery in our department for more than a year. It's still at the beginning, but we had amazing feedback from the patients that otherwise, in my personal opinion, I believe they would have struggled in between A&E, finding a slot at the GP to change the dressing, even finding someone to have a look at their wound and see this is good, this is not good, you may need this, you may need that. So the follow-up, especially for the day case surgery, is inexistent in NHS because you don't have slots to follow them up. You don't have time to follow them up. So it's either them struggling in between the GP and the A&E. We know how crowded is the A&E and how much time they had to spend there. So honestly, the feedback that I had from most of the patients that they have been follow up is just it's amazing to have that reassurance that at the end of that whatever you're typing in of the end of your phone is someone there that can take care of can give you an advice and put your mind to reassurance or plan the meeting accordingly if they need it, if they really need it. I remember my first patient that I reload in with a post-op. So it was basically just the beginning, and I had a very difficult gallbladder. The patient told me from the beginning. She said to me, I'm known to have wound infection. So every time I had the surgery, I end up with wound infection." So I was thinking, it's fine. I'm just going to do, I know it's a difficult gallbladder. I'm going to do hopefully a laparoscopic cholecystectomy. So that would minimize the chances of you getting this infection. But obviously, as luck is always working, she turned out to be an open laparoscopy converted to open surgery. So obviously, like she said, she did got the wound infection. So it was like I said, just the beginning. So I was struggling. What do I do? Do I bring her to ESTEC? She will need continuity of care. This is important with a patient like that. You need to know how the wound was previously, what sort of advice has been given, when to bring them back. So it was a month later, within the struggle, that actually we've tried post-op. And I think she became like a star with the post-op. She has been invited to a few presentations because her experience, even though that wound took months to heal, which otherwise I think it would have been a very lengthy journey and troubled journey back to the GP or to A&E or to find slots. So she has been really pleased and really grateful for this. So we adapted, and it was work in progress. We've learned as we enrolled patients. There are quite a few currently running now, and
So you're happy with the first case. So what you've articulated, I think, is around the lack of a plan for post-op patients generally. It's ad hoc, there's no consistency as described earlier, and it's fragmented. And patients don't get a good deal overall, I feel. around how you manage the expectations. If you look at simple things like paperwork or some instructions post-op, for example, they're non-existent. Each hospital has its own version. Each surgeon might have his own version, for example. Even
Absolutely, yeah.
communication isn't
Yeah.
consistent. I find that shocking when everything else is standardized to a certain extent, but yet this whole concept of post-op care, whatever that means, lacks this whole kind of a sensible way of managing patients. So, Chinda, back to you now. So we've defined the problems and some of the cases that Adriana's mentioned and Ashish mentioned about the problem they're trying to solve. What is post-op AI? Tell me about what you've created to allow us to do this better going forward.
Well, first of all, I recognized that patients outnumber us in our ecosystem, right? And we were creating solutions that focused mainly on clinicians and how we deliver healthcare. I mean, this is historically what we've always done, right? You go to a doctor and they treat you. But time has gone way beyond that experience to where patients today expect something more. The younger patients, for example, will come in with a Google app and say, hey, this is what I feel I have, and this is the treatment I need. Patient expectations are changing. And like Ashish said, I wanted to control or have knowledge of the journey of my patient from the booking to theater all the way to recovery. This allows me to give them the best treatment and to get good outcomes. So when I focused on the concepts of patient experience and giving control of the journey to clinicians, we developed post-op in conjunction with patients and clinicians and said, look, what would you guys want? We asked each stakeholder. They had very differing opinions. Patients wanted reassurance, clinicians wanted more control, nurses wanted more time. It was very interesting exercise. And somehow we managed to collate together what everyone wanted into this platform. And we just let it run. And we kept learning from what they were saying of what their needs were. But the one thing that we focused on is we were very, very clear from the beginning to identify what was process-related problems and what was clinical problems. Because often the tendency is to try and fix process-related problems, like sending an email to a patient or an SMS or calling patients, ignoring the clinical pathway.
Yeah.
Right. So as a clinician, I felt as a domain expert, I had advantage where I knew what the clinical pathway and the experience was.
Yeah, so look, I mean, you're right in that sense. So one of the things that I think we've done well with is having the patient-facing platform rather than being all clinical, for example, right? So when I talk often about computers and AI and the future of healthcare, we often talk about the UI and the UX. UI is the user interface that we integrate into our platform, our smartphone, for example, and the UX means the user experience. We use that all the time in developing apps and platforms and solutions. A few years ago, I proposed a different pathway, and I called them the PX and the PI.
Yes.
Is the patient interface and the patient experience, the PX, which we often ignore when trying to create these solutions going forward. So I'm really pleased that you think about the patient facing, how do we involve them, how do we bring them to light, because they are going to empower any health service. What we're going to do, of course, is understand those patients that are less risk that can be managed remotely, post-op managed. Those need to come back, for example, for risks or complications. That's kind of what we're trying to achieve. So from your perspective, Ashish, you've been using this for a while, I understand. You've been trying to work out the pathways and where it might be of value. Give us your shared experience over the last year, what you found so far, Ashish.
Shafi, so I tend to be careful about following up patients in that when I started as a registrar in catering, or when I became a consultant and took over somebody else's patients, I had to spend nearly 3 months weeding out the patients who were following up every 6 months. And largely mine is a virtual telephone-based follow-ups because the mathematics is very clear. For every follow-up, the NHS gets a remuneration of whatever, £70, and for a new patient, it's 140 the trust gets. So it was converting. My aim was to get around 80% new patients in every clinic and 20% follow. So with an imperfect digital system that the hospital has, how do I still keep that control, me be confident that my patients are not at risk? And that's where I was quite interested in when the post-op app came. And I think the users are increasing all the time. So I use it for my colorectal patients. They're onboarded onto the post-op app. At the minute they're onboarded when they come into hospital for their treatment. And then I give them a well-being call after they get discharged. But then a couple of our nurses man this app 5 days a week, not at weekends. And the patients it's very clear to the patients that if there's something which is urgent or serious, they must contact the hospital directly or come to A&E. But otherwise, it has kept those patients out of their GP surgeries, out of A&E. Somebody has a redness around the wound, they just click a picture, send it in, and we can even send them a prescription if needed. If they were to end up with their GPs, a lot of these would be termed as surgical site infections, whereas a lot of them are not actually. It might just be a collection. I've not used skin clips for nearly 3 years. All the wounds are, it's an absorbable subcuticular suture with skin glue on the top, and I haven't even used dressing. So the patient can see what's happening.
Yeah.
It gives them the control. The next step is to actually onboard them when I see them in clinic, because the app can be loaded with all the information that is needed, our enhanced recovery pathway. It can have a virtual tour of the ward so they know exactly where they're going to be. It can give you the information leaflets. And after the operation, it can even be used for PROM scores, for like your low anterior section scores and things like that. So it is a very important tool, and the users are just increasing all the time.
Which is great. And that's what we want. We want traction, we want people to use it, give feedback. It makes sense. If I look at the surgical pathway, Chindu mentioned earlier in his first conversation around the WHO classification and the checklist. And so it was digitalized part of that process at the beginning. We do checklists, it goes on to often now computerized, etc. Operations are now more computerized on electronic health records. Yep, in terms of the operation record, the data that we present, etc. But then when it comes to post-op, it becomes analog. All of a sudden, there's suddenly a barrier that we just revert back to analog system, which I find really interesting, when everything else has become more digitalized. The future, of course, is digital. And Rena, from your perspective, I'd love to get some more understanding about the feedback from patients. Obviously, you've been using it for a year, and that's always been the most valuable lesson for all of us. What have been the kind of the positives around it, and perhaps some negatives that maybe things could be better? I'd love to hear your balanced view on the use of a post-op agent, if you like, or a process to allow people to get better care.
So if you're thinking of a patient after surgery, let's say I'm doing a simple thing, the most simple thing surgically wise. For me, it's simple because I've done it before many times. I know how it might go after that. But whoever is non-medical and if non-surgical, that's a complete journey. That's an important journey that takes over the entire recovery in the post-op period. So previously, we sent patients home with a little leaflet that was printed, sometimes on a bad piece of paper, and I don't think it had all the informations that a patient responding to a problem that a patient might encounter at home. I don't know, it's pain at 2 o'clock in the night that gets better after so and so. So this has not been covered, and their journey after the surgery, which I think it's an important part of their entire experience. We have forgotten about that. Initially, when I have started in NHS, which is actually 14 years ago, as a registrar, we had time to follow up patients. And gradually, I've seen that we moved from following them up after that, and some of the consultants used to follow them up even for years, in all honesty. we don't have time for follow-up now. So they are left somewhere, send you had the surgery, you go home and deal with it, because who else is there to help you? If you have a problem, come back. Either contact the GP, he can send you back to us, or if you're very open to your patient's experience and you like them to have a good journey, you tell them, contact my secretary if you have a problem, or go to A&E. So this was before we have been introduced to the post-op app. Now, with the post-op, they feel taken care of. There is somebody there that can answer to their questions. Like Ashish said, they can upload a picture from home. I'm worried. I think it's a bit of redness here. What do I do? Do I need to be seen? Is it okay? Because I've seen wounds before. I know that bit of redness might be nothing. It might be part of their process, normal process of healing. So it's reassurance, guidance, that the idea that someone there that can answer to their anxiety, because post-op part of recovery, must be a lot of anxiety. Am I doing the right thing? Am I lifting the right weight? Is 2 kilograms enough? Am I stepping right on this feet in regards to orthopedics or whatever they have with the orthopedic surgery? So it's basically reassurance. Somebody is there for them. It avoids unnecessary trips to A&E, waiting in a car park. We know that, I believe, everywhere it's a problem with car parking. So
It is.
simple
And it's
things.
expensive as well, right?
Yeah, so simple things like this, it's changing entirely the experience, the recovery. And if you think of it, not ultimately, their capacity of returning to work in good time, because we might be able to pick up complications at the beginning. If somebody is worried, doesn't have to wait for a week until the GP has an appointment, doesn't have to wait for 9 hours in any to be seen. So yeah, it's important. Um, Mel, which is one of our nurses that does amazing with following up post-op patients, received an email from one of the patients addressed to the CEO of the hospital, which really impressed me. So the patient in itself advocated for the post-op to continue, because it helped his journey and improved his journey, and it does that, I believe, for all the patients. So
And that's
oh,
great in terms of getting feedback, and that's really important. I'm really glad that you're getting success out of this. But in terms of surgical acumen and surgical kind of honesty and transparency, if you imagine at the moment the big cases, complex cases that you will do in terms of cancer work, etc., those complications usually come back to the hospital. You know about them. A lot of the minor operations, the benign cases, for example, like the lap coleus or the hemorrhoids, other things you might do, we discharge them on the day of the operation. We don't really have any follow-up for most patients, because the way that the tariffs work, you're not really rewarded or paid to see those patients again. They're supposed to be discharged managed in the community. So the question for me also is around, how do we assess our competencies? How do we know how many complications we've had? Because surgeons would like to know the complication rate, but we don't really have a handle of that. And I think these ideas, where we become more digitalized and have patient communication, might get better accurate reflection of figures on that. So that's one thing that I think is important. Ashish, what are your thoughts around that? Do you think that we're going to get better data because of it?
I think so. I mean, we can construct patient prompts, sort of
Yeah.
leaflets, and just a simple contact. A lab colleague which has gone home, you know that most of them are going to be absolutely fine within a couple of days.
Yeah.
The ones who are not, you end up again. But if you want to know about hernias or lab colleagues, send them on the post-op app, just ask them to contact us back at, say, day 30. You know, that's your month's follow. and you just construct your question. So you've got that and it's so easy to analyze these things through the app itself. So absolutely. We actually going to think about helping our colorectal CNSs with the surveillance of colorectal cancers by using the post-op app as well. How we integrate it with the hospital systems, and yes, there are loads of different apps. So, I think as an NHS, we've got to be careful about what we select and not sort of duplicate efforts. But yes, I think follow-up is going to be all the better. And this patient who sent this email in, he's crystallized it into 5 points. If I might just go through that, it saved me being at home and worrying about what was good and what was not good in my recovery, wound, pain, feeling, and thoughts. Saved time and money with my GP and my caring colorectal team by not having to go and seek an opinion, help, or get a question responded to. Saved time and money at accident and emergency by not having to attend. Save time and money for both the NHS and patient by not having to attend an early follow-up appointment to check the wound and to respond to any patient concerns. Saved on car parking, the green part of it, the green angle. Encouraged and supported me throughout my recovery. So, he is in control. You've empowered him.
Yeah, it's about patient empowerment. It's having patients that are driven by their own healthcare. We're seeing that change. We're seeing a sea change in healthcare from basically being proactive to not reactive. We're seeing people now are getting empowered and understand their health much better. It's kind of the way we're heading towards. We mentioned earlier about outcomes, Chindu. And one of the things that, say for reimbursement, that's important, is understand those outcomes much better. In fact, we're going on to a whole level of where the reimbursements are purely based on outcomes. Yep, we know that, especially in the US, where I think you're now trying to get to the market and get some traction. So what are your thoughts around reimbursement models of post-op care? Because that's always going to be the one that drives change. I get the PX, the patient experience, absolutely, we've got to do better. The data, absolutely. But the thing that drives change is where the money lies. How do you get paid for it? How do you get reimbursed? I'd love to explore what your thinking around that is.
Yeah, you hit the nail on the head. So many years ago, probably a decade ago, I had the privilege of attending Kellogg Business School, where they drilled into us that healthcare stands on three legs: access, quality, and cost. What I wanted to do with post-op, and when we started out as a team, was we didn't just look at the NHS. We were looking at surgery around the world. 300 million operations a year, 4.2 million people die in the first 30 days from complication. Third largest cause of death in the world. Cost the world economy $12.3 trillion.
Yeah.
Now, this is a big problem to take a bite out of, right? So when we looked at the problem, we thought, okay, like you said, there's digitization in the West. Most hospitals have EPR systems, etc. But what about the rest of the world? They have no digital, there's nothing, right? We operate on patients, discharge them home, and we don't basically see them ever again. So the challenge was, how do you solve this? Through good access. So most people have a smartphone. So we said, okay, let's make an app, right? I dislike calling post-op an app. I think it's more of a digital tool to enable us to follow up patients or do perioperative care, preparation of patients and follow up. And the idea was, can we standardize the access? Can we standardize the quality? And then once we've done that, the real meat is how do we standardize cost, right? Now, healthcare is probably the only ecosystem I know of where the cost revolution has really gone in. If you look at Grameen Bank, for example, from Bangladesh, and Muhammad Yunus is an inspiring guy, what he has done for women who couldn't get loans, right? So we wanted to create what we call a blended model of payment, where one day, who knows, we could see a model where data, microfinance, microinsurance, and normal cash payments would all be blended in, like we buy shopping with Klarna or credit cards, etc., to pay for healthcare. But in order to do that, we needed to identify a currency, and the currency was data.
Yeah.
Right? Everybody leaks data, right? Why can't we use data to maybe create an equitable health model? But then again, you have to go back to adoption first. You need to convince people, look, there is a transparent, very definite pathway for surgery. We're very lucky in surgery that once a patient has had surgery, they have good outcomes. Now, you're very right about payment by results and payment by activity. So value-based care has been around for, for a good number of years now. Prof. Porter has been talking about for decades now. But getting it practically done, say in the US or even in Saudi Arabia, where they're way ahead of the rest of the world, I think, it's still a challenge, right? Because they don't have the tools for it. And we were hoping that post-op would be that first tool where you could actually use it in surgery and try and create this new model of healthcare where you pay by outcomes.
Yeah. So look, and thanks for untangling that conversation. I think about the bigger picture on a global perspective. The fact there's inequalities of healthcare, the fact that there's countries out there who are not very digitalized. How do you help support them? Access and quality and cost have the three axes, of course, that we will think about when providing care. Um, I'm going to come to the audience in about 5 to 10 minutes. Could you all think about questions to pose to our esteemed guests? We'll come to you in a moment. But let me ask you another question, all three of you. Do we need any of this? In the world of AI coming in and agentic AI, using agents to manage post-op care, post-op management, for example, having someone supporting the care, asking the right questions, understanding the complications prospectively, and then dragging out the risk, for example. Isn't the future embedded with agentic AI? That's a question I asked the audience. Are we ready for that at the moment? You mentioned the divide globally, of course, but AI is going to have the power to overcome some of the inequalities, I think. I've been saying for 10 years. But actually, isn't that part of the model? I'd love to get your thoughts. Chindu, you first.
Yeah. No, I was actually thinking about agentic AI today, funny enough, because we had a specific problem that we wanted to solve, and I thought agentic AI would be an ideal solution. Um, AI is a scary word for a lot of people, particularly in healthcare. I'm all for regulation of AI, and but more than regulation, I'm all for clinician and patient engagement with AI, because you can't have AI top down. It needs to come from the clinicians themselves for them to understand where can AI help them on their pathway. This is the challenge because a lot of us are not very familiar with new tech. We are happy users, but we're not happy initiators. You know, we have better things to do. So agentic AI definitely has a role in making mundane, repetitive tasks, processes very simplified, understanding complex relationships, and processing information at a quicker speed. However, I would find it very challenging to see it replace the human touch. And by the human touch, it's really hard to describe that. I think if you're a sick person and you go into a hospital, hear that first kind word or cup of tea, you probably know what human touch means. I don't
Do,
think
do we
agent.
have human touch in post-op care? We just mentioned how fragmented it is. At the moment, you were saying it's a message, it's an SMS, it may be a phone call, for example. Where's the human touch in that? I'm just being
Yeah.
controversial.
No. Don't have to be. This is where we spend a lot of time with our UI UX team. By the way, they are one of the best in the world, based in Milan. And they're called Things. And what we've been trying to do is recreate that human touch digitally. So we tried a lot of things. For example, the application itself is available in 20 languages, right? So if we speak Arabic or Polish or anything, you have that familiarity. The interface, like you said, the PI or the PX is very patient oriented. We create little smiley faces. One, in fact, I remember one patient telling me, "Yeah, I see all those questions, but what I really like is that post-op smiley face that keeps popping. That makes it brightens up my day." That is human touch. That's really hard to recreate digitally, believe me.
I'll tell you a story. You know, when you go to the airports and it says, "Was our service good?" And you have the emojis, happy
Yeah.
or sad. That person who designed that is a multimillionaire. Do you know that? A simple emoji
Yeah.
where it just says, "Are you happy, sad?" That data came back to let people change their services. So things like that make a big difference. So I get that what you're saying. Adriana, don't we need to kind of have a Dr. Adriana agent that appears on your screen after your lap code is a different one that you did? It says, "Hey, don't worry, here's Adriana. Let me take you through the process. I'm your AI agent." What do you think, Adriana?
Absolutely not. You're not going to replace me with an AI agent.
No, we're going to be augmenting, making you better, Adriana. No one's
No,
replacing.
leave me as it is. I like myself. So I think AI should be a tool. You know, when I first went to Barclays, they have a logo that money can be an excellent servant, but a terrible master. So I really loved it, and I remember that. I think that's the same with AI. It should be a tool for you. It should make our life easier, improve it, but not control it. So the agent AI no, I think I would like, yes, have videos about you can post videos, post-op care, what to do, what not to do, what's better to do after lab chole, what not to do after lab chole. Have videos like this, but I think the patient, because the patient is not an agent patient, not an AI patient, it will need a human interaction, and the human interaction should be with it can be helped with the help of AI. So AI, yes, as a tool, no for an agent AI. Adriana,
Not Dr. Adriana AI.
no.
Okay, Ashish, your thoughts on that question, and then I'll come to some of the. Please, the audience, please do put some questions in the Q&A, so we come to the our panel at the
Right.
end of the.
So
Yeah.
I don't think it's something to be scared of, and I don't think they're mutually exclusive, all these things. So, in a perfect world, virtual ward, something like the post-op app or some similar app to be reassurance to the patient is important. And that's where AI can help because, again, you're going to have various devices coming in, like your wearable devices, which are going to give you parameters, and they will also feed into these apps soon. That's bound to happen. The human touch starts in the hospital. When I first see my patient, the way I talk to them or hold their hand, I wouldn't do anything that I wouldn't want to be done to me or my family, and that's my motto. So basically, that's where the human touch starts, and it doesn't end there. I've got to inspire that confidence that you're going to be looked after. And for me, another thing of something like post-op app is like in India when I was in training, I went to a conference and there were two eminent surgeons sitting there, and one said, "I have no complications at all," and other guy said, "Yes, because all of your complications end up with me." I want to know my complications. I want to know my results, and this is the way that I can get them back to me.
And that's right, Ashish. I think all surgeons are honest. They will know their outcomes. They want to know kind of what the results are so they can assess better. Because we want to be better, we improve our services. And I think that's actually paramount of being a surgeon, understanding your complications, the numbers. And we've seen more transparency over the last 10, 20 years, certainly since the cardiac case in Bristol, which kind of highlighted issues around complications, how we should volunteer the information on a global level. Now we're hitting national records of that going forward. There was some of the questions. Here we go. Right. A few questions to go through to the audience. I think it's about time. A question from Oluwafumbi Olajide. I hope I pronounced that right. Apologies if the pronunciation is incorrect. And the various units that use the apps, to all of you, who mans the app and responds to the queries? Is it the surgeon or a trained nurse? Is there time for this to be incorporated into a job plan, for example? So I guess it's around using that time more efficiently. We'd love to know about the mechanisms, Chindu, of are you reducing the time or increasing people's time?
Yeah. No, this is a very pertinent question. In fact, it's the first question I get asked every time. And if I had
And it came up first in the query.
I had a penny for every time that question came up, I wouldn't need to work. So the question I answer usually very cheekily with another question. I usually ask them, what do you do now? Right? Once you have a patient you're discharging, what do you do? Like, do you just send the patient home? Invariably, the answer is no. We give them a telephone number in case the patient wants to call us. And then who picks up the phone? I don't know, somebody, receptionist, one of the nurses, etc.
Who does pick up the phone? Have you found out? Because I always give these leaflets out with a number. I've never worked out who actually answers that phone to this day.
The first thing to understand, Shafi, is that, look, let's be practical and honest here. Surgeons don't have time for this because we
Yeah.
are busy in theatres and etc. And I don't expect surgeons to be spending time to do this. However, we do have enhanced recovery teams. And in some cases, we do have infection prevention control teams and there are many teams around in a hospital, but they all work in silos. So one of the things that we've been encouraging is these silos to come together and use the same dashboard. So for example, when a patient's discharged from hospital, we say, well, instead of giving them a mobile phone number to call or to the ward, just tell them to leave messages on the app. And what
Mm.
happens in Kettering, for example, what Mel does is she checks the app once a day or twice a day and answers the questions, which means that 99% of all the questions are answered. Patients don't need to go back to their GP, etc.
Mm.
Now, I know that a lot of departments probably don't have the resources for this, but they do have checks and balances in place to answer questions from patients who've immediately left the ward. So what we say to them is just replace your mobile phone with the application. You have more transparency. In fact, the funny story about this is I find it amazing that you would have an experience where a patient seen a wonderful surgeon in a wonderful hospital, had wonderful surgery, was discharged back home. The patient had a problem 3 days later, called the ward, and they said, no, 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 we'll see you straight away. Come back in. Patient was seen the next day. Again, reassured, patient went back home. It was fantastic service. The patient felt it was fantastic service. But we never challenged that thought because, in my view, at least, is you've just asked a patient who's had major surgery to return 3 days post-surgery in pain, come by transport, park their car or whatever it is, pay for parking, walk to your clinic, and we're always busy, so we can't see them immediately. Wait a little bit, see them, tell them everything's fine, and they go back in pain, and we all congratulate ourselves on a wonderful journey that an experience we've given the patient. It's ridiculous. We've just exposed that patient to infection, pain, and whatnot. And this is why we never challenge what we've always done. In fact,
Yeah,
what I wanted to do with post-op was instigate people to challenge the existing practices to see
of
what
course, of
can
course.
move.
Yeah. And that's kind of, I think, part of what we should be doing every day. If you're not challenging the system consistently, then you accept what I call mediocrity by definition, because you're not changing or evaluating something different, for example. A question from Ib's iPhone. So Ib's iPhone is asking the question, and the iPhone is asking the question, where do you see the role of a peri-op app integrating the MDT team in the handoff and management of the patient post-op and pre-op? So I guess it's about we have post-op sheets, we have handover sheets, which has been going for forever, where systems in place. So how does that integrate? Integration is always going to be the key. Integration, interoperability, two questions that always come up, Chindu, from your
Yeah,
perspective.
yeah,
Have you had a chance to integrate that into, say, Cerner or Millennium or one of the other platforms?
yeah. So we're partnered with Oracle, Oracle Health, no longer Cerner.
Cerner,
But
of
the
course.
thing is, we built this intentionally as a standalone unit, simply because, like I said, our ambitions were global. We knew that 95% of the world didn't have EPR systems.
Sure, sure.
This to be existing on the cloud. Our integration was primarily focused on clinicians' pathways, what they did in real
Mm,
life, right? Rather than focusing on integrations with electronic patient record systems and whatnot, we focused on the clinician's journey and the patient's journey and said, look, this is the clinical pathway, this is the ERAS pathway. Where can we inject ourselves to add value, right? So yes, we can. We have open APIs. We can integrate with anyone. We're integrated with NHS Digital, for example. But actually, the integration should be with our own clinical practices.
yeah. That's really helpful. Heidi has got a question, and I guess it's back to what we were saying earlier about reimbursement models and payment models.
Yeah,
And I think she wants a bit more clarity on
yeah,
what that might mean. Have you explored the US market? I know you are, and you're trying to get traction in that market. They have completely different models of care and reimbursements, okay? It's almost incentivized for people to be seen post-op because you get paid a second visit, for example, although some of them are package deals and whatever. Have you tried to untangle that and say, hey, in the US market,
yeah,
how can we make this worthwhile? And also in the NHS, based on the PBR tariff.
yeah. So let's take a step back and understand that in healthcare, there are three layers as I see it. One is the clinical layer, as we see a patient, we treat them, etc. And that's based purely on clinical logic. And then there is a layer of payment on top, which
Mm.
causes us to send patients to different places because it doesn't follow clinical logic, but it follows a payment logic. Now, on top of that, we have a digital transformation layer where now we have to bend over backwards, or patients have to bend over backwards to follow a digital pathway, right? So we're moving further and further away from patient experience. Now, when you look at different countries like the US, you would imagine, yes, they get paid. They have a CPT code for follow-up, right? So I think Medicare pays about $166 per patient per month or something. I spoke to clinicians there and they said, you know what? I know they're supposed to pay, but they don't pay, right? So when you scratch beneath the surface, there's a lot of problems, right? If you go to India, for example, most of it is cash in hand, right?
Yeah.
If you go to other parts of the world, there are different ways of paying for healthcare. So,
Yeah.
like I said, data is probably one of the few currencies that are very common. And I'm inspired by M-Pesa in Kenya and how they've managed to use that. So to answer Heidi, data payment is a very interesting topic, which you could talk for hours on it. But what I want to say is that when you look at the different pay models around the world, one thing's for sure, we need to relook at how we fund healthcare. And it can't be based on activity. It has to be based on outcomes, right?
Yeah.
And with GIRFT, one of the best things that I felt about GIRFT was finally we're measuring, right? You
Mm.
have to measure.
Yeah.
Without measuring, you can't make a change. So someone out there saying, look, here's the measurement, right? Now you have the information, go do something with it.
Yeah. No, you're absolutely right. I think we should think about the reimbursement model that if, for example, the complication is not picked up and it's has an additional, so for example, if you don't pick it up early enough, it becomes a problem. They either need for a wound infection that might be dressed or packed, for example, or reopened, or another complication that might lead to further problems. That cost to the NHS or the health system is unaccounted for. It's blurred into the whole health system. So it's understanding what impact that might have and saying if we predict it, prevent it, how much could we save? So sometimes, Heidi, it's not about saying what is the cost and how much do we pay for it. No, it's how much do you save in the long term. And that's harder win for the health service because health services don't think about the long-term picture sometimes. It's always short-term gains. And that's we have to start thinking about the value-based care, outcome-based outcomes, for example. So that's a different mindset that's happening now. Insurance markets in the US, around the world, thinking around that side. And so, how do we value prevention and proactive rather than reactive care? And I've been talking to many insurance companies globally around that. A question for
Could I just
oh,
say
actually,
something,
please do
Shafi?
come in.
Sorry.
Of course.
So I think what you're saying is also relevant to the person who asked about should this be included in job plans?
Oh, yes.
Because it's only when the post-op app can show us what we're actually saving by avoiding returns, avoiding sort of GP visits. Now, the problem is
And
that
avoiding litigation as well. Remember, Ashish? And litigation, right? It's big for
absolutely.
the NHS, right?
Yeah. So once we actually show our management that cost, then it actually pays for another nurse to man the app because it is. You see, at the minute we are probably enrolling a fraction of patients who could be enrolled. As that number increases and across all specialties, yes, we're definitely going to need more people manning the app to make it effective. But that's how we show it. That's how we show the benefit.
Thank you. Sharon's got a question. Does the app have the option to save contact information, share directly into patient records so that follow-up can be appropriately logged? I think we've answered that in a sense. It's a standalone device at the moment on the cloud. There's no real integration because I think Chinda's mentioned it's more of a global problem he's trying to solve rather than say integration at the moment, but I'm sure
Well,
that'll happen eventually, Chindu.
yeah, so sorry, it's a standalone platform, but we are integrated into NHS PDS, which means that you could type in your NHS number and
Yeah,
pull
yeah.
patient data. Now, PII or patient information that is identifying them, we kind of always keep aside and protect it because we don't need that information. I think you can share information about patients with an EPR system or the NHS, etc. So post-op is meant to work in any situation. You could pull it out in the middle of the desert and still use it if you have internet connectivity on a mobile phone or a smartphone, or you could be in a very technical environment and still use it.
Yeah, thank you. I think we lost Adriana in that conversation. Hopefully, she'll rejoin us because I asked that question. In fact, Mr. C. Constant above, I think he says the thing that Adriana's back. Give her a second to join. Adriana, are you with us again? Or is this your AI appearing? In fact, the conversation is actually that very point. Mr. C. Constant says patients do better and complain less when they feel like they're looked after by a surgeon. Absolutely. It's that communication that's key. The lack of communication that often affects the problems and issues for the patient care. And surgeons face to face or whatever it is better than avatar and AI, and AI is never replaced. I think we all agree that AI won't replace us at all. But the world is changing, moving fast, and AI will have a role to help support us. And Adriana, this is back to you. We were discussing earlier that we couldn't possibly replace Adriana. We wouldn't want to either. Is how can we make your job easier, Adriana, with AI? I think that's the conversation to have. Adriana, where do you think AI could add value in your care and your time that you have as a surgeon?
But Shafi, we are already using AI to help us all sorts of things. Now, I've seen junior colleagues that are looking up for different topics. That's a help.
Yeah.
That's a small example of a help. So, in all aspects, it's going to be in theater. Robotic is going to be based on AI, and that's the future. Integrated care, that's going to be the same AI, which can fail you sometimes, like my phone failed me because it was overheated. So it has good parts, bad parts, but that's with everything that we're doing. It's just picking up the right things for us to help them in the right time. I don't know, it's while my phone was dead, so technology failed.
AI was suffering burnout. Is that what you're saying on your smartphone?
It was suffering a burnout.
Even AI
Yeah.
has burnout issues. Okay, Hussein's got one last question, and then we can stop
It
it there.
couldn't manage the temperature.
Yeah, exactly. Hussein, question for you. Thank you very much for your feedback. I guess he's asking, I'm wondering what would be the impact of digitizing post-op care on staff? Does that make it more work for them? Will they be abused by the questions being asked, for example? And I can answer Hussein very quickly. Patients are very pragmatic about how they use services. For example, if you give them a phone number or access, they use it most of the time, I'd say over 90, 95% appropriately. There's always one or two who might phone up for reasons that might not be necessary, but they get reassured. Do we know about anxiety in patients, what they need to be asked about? So we don't know the answer about the level of anxiety, level of understanding. Sometimes it's just lack of communication. I've seen that over my 32 years. So I'd said actually, the more information you give patients access to phone numbers, or actually they are less likely to give you a ring. In the past, I've often given my phone number out to patients. Yeah, here's phone number. Have a problem, let me know. Honestly, I did that 10, 15 years ago. I was hardly ever caught with a problem. It just meant that they were confident in your honesty and transparency and that you were available if they needed. Chindu, last question, point for you.
Yeah, I really want to touch upon this particular point that you mentioned. So I used to do some moonlighting at an A&E hospital in London while I was making the app. And what amazed me was people would wait 5 to 6 hours to see me. They would come in to the consultation room and sit there and say, Doc, I know you're busy. I just need 5 minutes of your time. And I said, no, you have all the time in the world. No, 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 you're very busy. There's a lot of people out in the waiting room. I said, I don't care. You tell me what you want to tell me. And at the end of it, I always tell them, listen, come back anytime. We're open 24/7. I said, no, 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 I can't because, you guys are busy, etc. No, no, I said, look, if you don't come back, I don't have a job. So please do come back. They never come back. The ones that you are sometimes, occasionally you say, look, I don't have time for this. Here's your antibiotic. Off you go. They don't like the experience. They go doctor shopping. They go to the next hospital, right? The same
Sure.
patient, same day. So we all know this. I mean, clinicians don't need to be told that if you are open and you tell patients, look, we are here for you, they don't come back. And the reason I say this is there is a big problem in the NHS and in healthcare in general, which is we're all focused on improving efficiency on the supply side. We completely ignore the demand side. The demand side is patients losing trust in the system. Now, if you look at the trust recent
Have
reports,
to you're very short, very quickly, because running out of time
yeah,
and the video.
absolutely. Yeah, sorry. So the trust is dropping, and we need to reignite that trust in patients by telling them, look, we're here, right?
Yeah.
And usually they don't come back, or most
Yeah.
of the time they don't come back.
I think trust is the right frame to right word to end this conversation. Thank you for joining us. Thank you for your questions. Thank you for interacting with us. This video will go up on the website, edited so you can see it on demand as you wish. As I mentioned before, we're running a big conference next year, the first of its kind for surgical leaders, the first one in the UK. So we'll be inviting people to come to that, and we will set up an amazing speaker agenda list that we'll share with you in due course. Look out for Surgery International as we launch the program next 2 weeks or so, and then sign up if you can make it next year. Thank you, Chindu. Thank you, Ashish. Thank you, Adrana. And we'll see you again for the next webinar in due course.